introduce the two laureates together because they are going to, they informed me, seamlessly transition one from the other, so from Alan to Chris. So here we go. Dr. Alan Lopez is the Melbourne Laureate Professor, the Rowden White Chair of Global Health and Burden of Disease Measurement at the University of Melbourne. And Dr. Christopher Murray is the Director of the Institute for Health Metrics and Evaluation and Professor of Global Health at the University of Washington. And the two of them co-founded the Global Burden of Disease Study in the early 1990s. They are being awarded, quote, for their groundbreaking work in conceptualizing and quantifying the global burden of disease. That study is a systematic scientific effort to quantify the comparative magnitude of health loss from all major diseases, injuries, and risk factors by age, sex, and location over time. Their first collaboration calculated estimates for 8 regions, 107 diseases, and 10 risk factors. More than 2 decades later, the latest edition of the study, now published annually in The Lancet, covers more than 300 diseases and injuries in nearly 200 countries by age and sex from 1990 to the present, allowing comparisons over time across age groups and amongst populations. A truly massive study. Approximately 3,200 collaborators in 140 nations contribute to what has been recognized as one of the world's largest publishing collaborations in science. Possibly the other one is the LIGO experiment, measuring gravitational waves. In recent years, the GBD has expanded into quantifying the socio-demographic inequalities in health and measuring health on the local level. The GBD has led to policy changes and improvements in health systems for countries around the world, including China, the United Kingdom, India, Rwanda, Colombia, Indonesia, and the Philippines. The United States National Institutes of Health, the World Health Organization, the World Bank, and the Bill and Melinda Gates Foundation all use the GBD studies and data results to guide their priority setting and spending decisions. Here to tell us more about this really important study and its impact, please welcome Dr. Alan Lopez and Dr. Christopher Murray.
Thank you very much, Alan, and good afternoon, ladies and gentlemen. Let me first, on behalf of Chris and myself, thank the Gairdner Foundation for this amazingly prestigious award, which we're very honoured and delighted to receive, particularly an award made for recognising what Alan was describing, the generation and use of evidence in health policy debates worldwide. And what I'd like to do to initiate this lecture is talk a little bit about the history of the Global Burden of Disease Study, talking about its characteristics, and then look at how those characteristics and outreach of the Burden of Disease Study have changed over the evolution of the Burden of Disease Study over the last 3 decades or so. So I'll begin with a brief outline of what is the Global Burden of Disease Study and then look at some of those changes. Alan's defined many of these characteristics, so I won't repeat them in detail, but it is meant to be a systematic scientific effort to quantify the health loss from as many diseases and injuries and risk factors that are considered to be of global public health importance. And it's meant to do that in a comparative way so that policymakers everywhere can compare the amount of health loss from measles, malaria, TB, traffic accidents, quite disparate causes of death and disability, as well as various risk factors. It's meant to do it for not just 5 or 10 diseases or injuries, but for every single condition that is considered to be important in global public policy debates. And hence we have over 360 diseases and injuries, almost 3,500 sequelae of those diseases and injuries, and almost 90 risk factors. And we do it for every year from 1990 to present, and every time we do it with new methods and new data, we go back and re-estimate the entire time series. So I won't say much on the methods of the GBD and present any algebra, but it's useful to summarize the methodological approaches that we use in the GBD. And by the way, I've talked about what is the GBD, but why the GBD is a good question as well. And I think you'd all agree, those of you working in public policy, that any debate about the importance of investing in health, where to invest health resources, should be guided by some understanding of the comparative importance of health loss in populations, what causes them, and how that is changing. It's not the only ingredient, but it's a critically important ingredient to have. And so when we measure the burden of disease, we recognise a series of challenges that I've listed in this slide, and we have a series of generic solutions. The challenges are not new to you, I'm sure. There's inconsistent data, case definitions. What one data set in one part of the world says is malaria might be quite different to another data set that we need to deal with, and how it defines malaria, for example. In many parts of the world, there simply is no data. How do you estimate lung cancer in Mali when there isn't any data? Yet we cannot have a global burden of disease study without estimating lung cancer in Mali and 195 other countries. There's often conflicting data, and that's, again, not a surprise that when we look at the data sets available to us, we get different measurements for the same entity in the same period of time for the same population. How do we resolve that? There's the classical sampling and non-sampling sources of error that pervade data everywhere, and the GBD data is no different. And then there are excluded groups. For example, the administrative data sets that we have in many countries on causes of death only really capture, in many cases, deaths in urban areas. They don't capture the deaths in the more rural and remote areas, and they may well have a very different profile of deaths and causes of death than those in urban areas. So these are some of the main challenges that we have in terms of the data available or not available. And the way we approach that is three generic solutions, methodological solutions. Firstly, we make sure that we do a systematic quality review on every single data source. And in the GBD 2017, which is coming out in 2 weeks' time in The Lancet, there are over 100,000 data sources that are used. And we need to do a quality review of each of those data sources and correct using statistical methods. For example, in causes of death, many countries assign the underlying cause of death to what we call a garbage code. Someone goes into hospital with lung cancer, eventually dies of septicemia in the hospital. Public policy is interested in preventing the lung cancer, not the septicemia. And so we need to know the extent of lung cancer as opposed to septicemia mortality. We often get these different diagnostic challenges between data sets, and we need to develop crosswalks so that we're measuring the same thing, the same quantity of interest in the different data sets, even though they may define that quantity of interest differently. And we then need to develop statistical methods that systematically allow us to cope with missing data, so data imputation methods, or to deal with data from biases in data due to missing groups in those data sets. Particularly the groups that are missed are often the poor people, poor populations with different cause of death profiles. So those are the challenges. What do we produce in each cycle of the burden of disease? Well, we produce the traditional metrics that people are interested in, that epidemiologists look for: incidence of disease, prevalence of disease, case fatality rates, death numbers. They all serve different public policy purposes, so we estimate those. But perhaps more importantly, to get a single summary measure of the amount of health loss in a population that we can compare from year to year or across geographies, we need to come up with a single measure. And the measure that we've developed in the burden of disease is this concept of disability-adjusted life years, by measuring the amount of health loss that will occur in the future from events that occur today. We do that both for premature mortality, YLLs, that's measured by looking at deaths by age today and multiplying or weighting those by the amount of lost life expectancy. Importantly, we also add to that as a form of health loss due to non-fatal events. You have a traffic crash, you don't die, but you have serious disability. Well, that's a health loss which you want to prevent. And so we measure that through the prevalence of those health states multiplied by a disability weight depending on its severity. It's all about health loss in the future. We add the two forms of health loss together and we get this concept called DALYs, or disability adjusted life years. And some of the results that Chris is going to show you in a moment deal with particularly that summary measure, which is comparable across populations, particularly when age standardized. The publication of the various cycles of the GBD is in various fora, but the primary one now that we disseminate our results through is the Lancet. Each year there's about 400 pages, a special issue of the Lancet devoted to the findings of the global burden of disease for that particular year. You can see here the covers of the GBD 2015 on the left and the GBD 2016. I don't know what the cover of 2017 looks like, but we'll all find out on November the 10th when the GBD 2017 comes out from the Lancet. So that's a very brief history of why, where the GBD came from and what it is, and some of the challenges, the methodological challenges, the data challenges that we've had to deal with. I think these are important questions for you to keep in mind when you see the results that Chris will present. But before that, I'd just like to give you a brief overview of the history and some of the important evolutions of the burden of disease. Chris and I are being honoured here for the pioneering work on the original global burden of disease concept, which was something we started in the early 1990s. And at that time, there was no comprehensive or consistent measure of health problems worldwide. I was at the World Health Organization. I would go around to programs and ask them, well, how many child deaths is your disease causing? And when I'd add up those child deaths, we were killing children 3 times over. And that was not because these people meant to inflate their numbers, it's just that advocates are not good epidemiologists. And so that was the challenge that Chris and I had. The original Global Burden of Disease study, when we were asked to do it, was done as the analytical basis for the 1993 World Development Report, which you can see up there. It was the first foray of the World Bank into health as a development issue, and the World Bank president wanted us to measure the amount of health loss worldwide, not just from death, which I had been doing at WHO, but also from disability. We published the preliminary results of the first Global Burden of Disease study in the World Development Report 1993, and there was an immediate request from the academic community to publish our methods, which we then did in these 2 volumes, each of about 1,000 pages in 1996, as well as a quartet of papers in the Lancet in 1997. Since that time, that was the initial Global Burden of Disease study, the GBD has evolved in a number of ways, but I'd just like to summarize 4 of the key evolutions of the GBD before I hand over to Chris for some of the results. And I think that the biggest evolution of the GBD has been its complexity and granularity. Public policy just needs to know at a more local level, from a lot more diseases and injuries than we originally quantified, what is the health loss from these conditions in my population and what I can do about it. And so the GBD 1990, you see the summary on the left there, we had about 10,000 condition, age, sex, location, years of estimates. About 10,000. And this did not include the sequelae, but about 10,000 estimates. By GBD 2016, that number had grown to 400 million, to show you just 43,000 times more, show you how granular the GBD has become. And you can see that in the table over there. If you look at any one of those rows, you'll see just how much more detail the annual cycle of the GBD has become. So, for example, if you take geographies, the second last row, we've gone from 8 regions of the world that the World Bank gave us in 1990 to 774 separate countries and sub-districts, sub-regions of countries, and that number now in GBD 2017 is closer to 1,000. Secondly, we've built an enormous global collaboration. Alan referred to the largest publishing collaboration in science today. Well, I'm not sure if that's true, but it'd be pretty close to it. We went from 2 people, which was Chris and I and a series of research assistants, 6 to 8 research assistants, one of whom is here with us today, Manuela Gakadu. That's all we had in the initial Global Burden of Disease study, and we took that on together to produce the first results. That is not a replicable methodology. Today, the global burden of disease is truly a global collaboration. As of yesterday, I think these numbers are correct, 3,641 collaborators in all of those countries you see there, 143 countries and territories, and where you see it in dark, countries like Australia, India, Iran, Ethiopia, Brazil, United States, we have more than 100 collaborators in those countries working on the global burden of disease, and in Canada, somewhere between 60 and 100. But you can see there are very few blank spots on that map. We have collaborators in virtually every country. We also have more elaborate methodological and scientific oversight. From what was essentially Chris and my judgment 30 years ago, we've now moved that into scientific committees and an independent oversight committee which looks at and advises on directions for the GBD to move into. A third important dimension that we have followed as well is this increased transparency and making the GBD a resource for other researchers. On the right-hand side there is a snapshot of the GBDX website where there is metadata on each of those 100,000 plus data sources that are used in the GBD. So you can see the input data that goes into the GBD, you can see its characteristics, its strengths and weaknesses according to what you'd expect to see about a data set. This was not the case 30 years ago. The GBD 1990, we published 2 large volumes, but even in those 2 large volumes we could not cover all of the information that people were interested in, particularly the primary data, nor the spreadsheets that we used. And indeed we published relatively little methodological detail, in part because it was methodologies that Chris and I were making up as we were going along, building the plane as we were flying it. But be that as it may, since then the methodologies have evolved, as I'll show in a moment, into something much more complex and appropriate for the importance of the estimates that we are producing for global public policy. And importantly, we follow and adhere strictly to the GATHER guidelines that have been developed for transparent health estimates reporting. Not all agencies, for example, the World Health Organization, does not do that, but we think it's important that we be as transparent as possible in how we make estimates and where we get the data source from. As we put there on that slide, all 108,000 data sources in the Global Data Health Exchange, the metadata is published and deposited in a GitHub. And finally, the fourth transition that I wanted to summarize is that we've moved from the immediate purpose of GBD 1990, which was the analytical basis for the World Development Report's packages on cost-effectiveness packages for countries at different levels of development in order to prevent health loss. That has now been superseded by, it's still there as a role for the GBD, but superseded, we think, by important developments in supporting other aspects of global health priority. So, for example, we've developed a socio-demographic index which demonstrates or measures the amount of health that you would expect a population to have at a given level of development and how much you observe in terms of the GBD. So when you've got a big disparity between observed health loss and expected health loss, that is a wake-up call for that population to do something about it. There is a new era now with the Sustainable Development Goals launched in 2015. The GBD is an ideal platform for countries to monitor progress towards those goals. We also develop methods for universal health coverage, provide the background, the basis, the analytical basis, the evidentiary basis for countries to assess the extent to which they're meeting universal health coverage goals, or indeed the amount of vaccine coverage that they are achieving, monitoring the impact of interventions to improve vaccine coverage. All of that is possible. We've developed a healthcare index so that countries can assess the extent, and we can compare among countries the quality and access to healthcare for their populations. Importantly, we've also developed just recently and published an estimate worldwide of human capital, education capital in populations in a comparable way and using a comparable framework that we use for the global burden of disease. This is an important, obviously, sectoral piece of evidence for education, but it's equally important for health, given the critical role that education has in health survival. So that's a very, very brief overview of the history of the GBD, some of the challenges, some of the methodological approaches, but more importantly, why the GBD today looks very, very different to what it did 30 years ago when we started. And to tell you more about what we find, I'll turn over to Chris Murray.
So let me add my sincere thanks to the Gairdner Foundation for Alan and I's work, along with many others on the GBD being recognized. For us in global health, this is the major award globally, and so it's a tremendous honor for us. So let me talk a little bit about some of the findings from the GBD. I'm going to give you some results that are unpublished. They'll be out in 2 weeks, some from last year, to give you sort of the high-level view first of what have we learned about global patterns. So on this figure shows deaths by age back to 1950 for the world. Deaths in red are in the first year of life, and then in orange are from ages 1 to 4 through to deaths at the oldest age groups in the dark purple color, for example, 95 plus. And one of the more profound transitions in the world is this enormous shift from mortality being dominated by deaths in the first 5 years of life back in 1950 to still unacceptably 5 million deaths in the world in children, but as a fraction goes, this dramatic transition where the median age of death, for example, has now gone up rather dramatically. Now, for those of you who are speculating on the huge spike in around about 1959 to 1962, that was the Great Leap Forward in China, which killed about 30 million people. And the Great Leap Forward translate the Great Famine. Now, another thing that we can do in the GBD is take this very zoomed out view of health and try to unpack what are the big drivers at the broadest level. And this diagram has, for all 195 countries, the life expectancy for each country from 1970 to present. So there's a lot of dots on this diagram. And we've colored the dots, or the life expectancies, for each country, red for the decade of the 1970s through to blue in the last 7 or 8 years. So you can see on the x-axis our measure of development, the socio-demographic index, and on the y-axis is life expectancy, and the black line is sort of the average relationship. So there's a profoundly powerful relationship between development and life expectancy, as you would guess, but equally there is a 10 to 12 year variation at the same level of development at every point in time in terms of life expectancy. Meaning what you do and what policies countries pursue and what interventions are delivered can make a very large difference on top of this general relationship with development. And if you look carefully at the higher levels of development, represented by a socio-demographic index above about 0.7, you'll see that most of the dots above the black line are blue, and most of the dots below the black line are red, meaning that there's also a technology shift, that over time, at the same level of development, at higher levels of development, not lower levels, we see higher lifespans or longer life expectancy. So we use this relationship, as Alan mentioned, to tease apart how countries deviate for all-cause mortality and by cause from what we expect based on this general relationship with development. Now, here's everything that you may want to know about causes of death on one diagram. You may want to know a little bit more detail, but this covers the main highlights. We've divided countries in this into 5 blocks of quintiles of development based on their status in 2016. Least developed in 2016 over on the far left, most developed on the far right. And we've divided causes of death in the GBD framework, which is a hierarchical cause framework. At the first level, we divide causes into 3 big blocks. Red is the communicable maternal neonatal nutritional deficiencies. Blue are the non-communicable diseases. And green are injuries. And on each of the quintiles, we also show time from 1980 to 2016. And you can see across the quintiles, there's a huge gradient in the communicable maternal and neonatal causes. we also see within each quintile, despite reversals like the HIV epidemic, a decline in every case of the age-standardized years of life lost for the communicable maternal and neonatal causes. We also see a decline in the age-standardized rates for non-communicable diseases in each of the quintiles, although that decline is certainly slower than for the communicable diseases. And we also see a decline in age-standardized rates for injuries, with the spiky pattern occurring as there's large catastrophes. For example, the genocide in Rwanda on the far left is the big spike. The Haiti earthquake is the second big spike around 2010. So this gradient makes you notice a number of factors here, which is there's a lot of discussion in the literature as well as in the policy arena of the epidemic of non-communicable diseases. That epidemic is not that the rates, age-standardized rates, are going up. That epidemic actually is shown on the next diagram, where we translate those rates, those age-standardized rates that epidemiologists like to look at, into numbers. And there, because of population growth and because of aging of populations, you have the number of years of life lost from non-communicable causes going up dramatically in 4 out of 5 quintiles, and it's flat in the highest income quintile, with maybe a little uptick, which we'll talk a little bit more at the end, at the very end of that diagram. You see the number of YLLs from the communicable, maternal, and neonatal causes going down, except in the lowest quintile, and you can see now the effect of the HIV epidemic there. And you can see that the number from injuries is going up in some parts and going down in other quintiles. So that's the sort of general global pattern over time and across levels of development for causes of death. If we shift gears and look at the other part of the GBD, which is prevalence of disease times the public's view of severity of those diseases, then you get a very different pattern. So lots of things going on in this diagram. On the top one, that's the age standardized rates, and the bottom set of 5 graphs is the numbers. But what you see here is that there's no trend in the age standardized rates. They were declining for mortality, not for disease. And partly that's because as global health, we're making more progress reducing case fatality rates than we are reducing disease incidence. Partly that's because the biggest causes of disability are musculoskeletal disorders, mental disorders, and substance abuse. And those, there's no trend at all. And add to that also dementias, which there's no trend in the age standardized rates. And so you get that flat line that we see for the NCDs, even though the volume of disability from the communicable, maternal, and neonatal causes in red is going down. And then, like with more causes of death, you see the big increase in numbers there due to population growth and aging. Now, we can dive deeper in the GBD cause hierarchy. So we start with that 3 large groups, and then you can go down to level 2 of our cause hierarchy, where there's 21 cause groups. And that's what's shown here. And this is just showing a simpler way to look at the results, which is the rank order of those 21 cause groups in 2005 and the rank order globally in 2016. And you can see at the top is now heart disease, diarrhea, pneumonia, and other infections is number 2, cancer is number 3. And other notable changes there are the big decline in HIV, AIDS, and tuberculosis from number 6 to 11 in the last 10 or 11 years. And, for example, the rise somewhat of neurological disorders driven largely by aging. This gets more interesting in many ways when you go down a level to more specific causes. So globally, the 2 leading causes of the burden of disease now, of course this varies tremendously by country, is ischemic heart disease and stroke, and then pneumonia. And here you give an example how a lens on the world that includes disability or functional health loss. Number 4 in the world is low back and neck pain, which is highly prevalent, and some substantial fraction of people with back and neck pain have quite severe functional limitation. Then you have diarrhea dropping down from number 3, representing the substantial progress in reducing under 5 deaths from diarrhea. Not very much progress at all in reducing prevalence or incidence, but mostly driven by reductions in premature mortality. And then road injuries as a global phenomenon going from number 8 to number 6 is another example of changes. And some of the global progress on some of the communicable causes, HIV, AIDS, malaria, shown by the substantial decline in ranks. Now, we provide online in a series of tools where you can explore these types of views of the world by country or subnational units at your will. And this is really just to give you a flavor of the broader overview and results that we see. Now, Alan talked about the importance of giving decision makers different views on their what's different about their community. So one is, just what are the leading causes of burden in your society? What are the trends in those causes? Another view is, compared to your peers at the same level of development, do you do worse or better than expected? And we can answer this question, and you can also do this online in the interactive tools for any of the outcomes we have in the GBD. This is for age-standardized DALYs. So this is the rolled-up measure of the totality of burden, and it's answering the question, what's the ratio of what's observed in your country to what is expected for your level of development? And we've also broken down some of the larger countries to subnational units, the United States, China, India, Brazil. And what you see here is perhaps maybe not surprising. A country like Canada is doing better than expected. It's in green. But there are many states in the United States, particularly in the Mississippi Valley and extending up through to West Virginia, that are doing substantially worse than you would expect based on their level of education and income and development. You also see parts of India that are doing worse than expected, and you see many parts of China doing better than expected. So the Chinese success in health is above and beyond simply economic growth, because we have, in this view, netted out that change in income and education. And you get a very different perspective here in a country like Brazil, where in northeast Brazil, even though there's a gradient from north to south, the government efforts over the last 25 years have actually moved the northeastern states from being worse than expected to better than expected. Still a gradient exists, but compared to this benchmark of what you would expect for development status, you get a different insight. The other view in the GBD is the view around the risk factors that drive the patterns that we see in different countries. And so we have 84 risks or a combination of risk factors. And in this analysis, we're asking a different question than in the traditional underlying cause analysis that's behind the list of diseases that I gave you. We're asking what fraction of the burden or premature mortality or death, whatever outcome you're looking at, would be reduced if each of these risk factors were reduced to their minimum risk level. So on this assessment, child and maternal malnutrition in 2016 is still the _1 risk factor. Now, I should give an editorial note there. In GBD 2016, we added into the risk list prematurity and birth weight as risk factors. And that moved child and maternal malnutrition up from being about number 6 or 7 back up to the #1 slot, because a very large fraction of neonatal death is attributable to prematurity or low birth weight. And neonatal deaths, because they're so young, contribute substantially to years of life lost. Number 2 on this list is a surprise, I think, to us, and it reflects how in this exercise of sort of rule-based synthesis of the available evidence, it's not always what you expect to see, namely diet, and we actually analyzed 14 different components of diet, turns out to be the #2 risk globally, and is towards the top in most countries, except some of the lowest income countries. And, if you drill into diet, it's not fat or sugar at the top of the 14 components. It's actually fruit, vegetables, nuts and seeds, fiber, and high sodium that are the key components of diet. High blood pressure is number 3. Tobacco and air pollution come in at 4 and 5. And then you can see number 7 there is high body mass index, overweight and obesity. And I bring your attention to that, even though it's only number 7 currently on the global scale, it's the one top 10 risk where the direction is quite substantially in the wrong way, that we are seeing the burden from obesity and overweight steadily rising over time. And that's a major challenge, I think, going forward. Now, one of the things that we've done in the GBD, and starting about 7 or 8 years ago, we've started making available the entire database of results from the GBD at whatever level of granularity that we publish online for researchers, activists, advocates, policymakers, and the general public to explore at their leisure. And one of our flagship tools for this is GBD Compare. You can Google that or just go to healthdata.org, and you can explore for whatever country you're interested in or territory the results that we have in the GBD through many different views. I'd like to give a little bit of a flavor of the granularity that Alan was talking about. So here's an example of the first administrative granularity. We published in April in the Journal of the American Medical Association our first US burden by state study. And there were lots of interesting findings, as you might expect, but one that captured the most attention from across our collaboration was as we drilled into age-specific mortality, what we noticed is that death rates under age 20 in every state in the United States have been going down, and death rates over age 55 in every state of the United States have been going down. But between the ages of 20 and 55, you have divergent trends. You have 21 states where the death rates have been rising, and you have a small handful of states where that increase in death rates is actually more than 10% over that time period. Kentucky, Oklahoma, New Mexico, West Virginia, and Wyoming. And if you go a step further and say, what's special about those places, it turns out that the increased mortality in these divergent states in the US is driven by opioids, suicide, diabetes, and cirrhosis. And those increases are larger than the further declines in non-communicable causes like heart disease. And if you're interested in the detail, it turns out that it just highlights how tricky it is to come up with assessments based only on rolled up measures like life expectancy. Because if you look at life expectancy, you'll miss this because things are getting better in some age groups and getting worse in other age groups. Happy to say that today, reflecting the ongoing nature of the GBD, we published the first second administrative level analysis of the GBD for the UK. This is a collaboration led by Public Health England and then the academic collaborators in the GBD, where for 150 local authorities, we've undertaken the complete GBD analysis of underlying cause, years of life lost, years lived with disability, and risk factors. And the two maps, the map on the left is the map of age standardized years of life lost, and on the right is age standardized years lived with disability. And they're highly correlated, but there's some notable divergences between the two, and you can see some of the spatial patterns that I think anybody familiar with the UK might have expected to see, with some of the authorities in the north doing much worse, and particularly Scotland. Now, the drive towards more granular data has pushed us to sort of ask, how far can you go? And in countries with high quality data, like many high-income countries like the United States, the challenge is not missing data, it's really signal-to-noise processing, where by chance there's huge noise in the measurements. And with the advent of computational power that's cheap and the reality of sort of modern Bayesian signal processing, we're able to produce these types of analyses. We published a series of papers in JAMA on county level causes of death, and we aspire to do the full GBD analysis at the county level. Here's one example of the county analysis showing liver cancer. And what's interesting here is until you look at the data, you would not have expected or known that there would be these enormous foci of liver cancer, particularly in southern Texas. I think it is a little bit better known that there's foci of liver cancer in Native American populations or reservations that you see in South Dakota, for those familiar with US geography. And if you look at the far right map, you see the rate of change over the 1980 to 2014 period, where even though they're not yet that high, along the entire West Coast, there's this large rise in liver cancer. Lots of theories. Is it Hep C? Is this a much more historically drug-using population in the 70s? But we don't really quite understand some of these trends. And it's the power of descriptive data to challenge us to ask new questions. Now, here's one that generates usually some interest, which is taking the all-cause mortality, life expectancy in the US, and taking each county and pretending like it's a country and giving it a rank across countries. And you can see there are places like Seattle, where we are, where life expectancy is akin to Japan. But there are parts in the United States, in the Mississippi Delta, where life expectancy is worse than 50% of the countries in the world. And so, it's just another way of showing results by converting it into equivalent ranks. But it's something that you can do because the GBD applies these very consistent, standardized analytic methods across geographies, both at the national level and at the subnational level. Now, what I'd like to do is just talk about a direction that Alan and I started 25 years ago and then left off for a long period, have now come back to, and that is forecasting models. So in 1997, we published as one of the 4 papers, the original GBD papers in the Lancet, forecasts. The model was an incredibly simplistic model. It was linear regression of log death rates with 3 variables on the right-hand side: income per capita, education, and smoking. That model stood for a long time. The only other set of global forecasts that have been produced by Colin Mathers used the exact same model, re-estimated it with data around about 2004, and that's been it for forecasts. And what we sought to do starting 3 years ago with funding from the Gates Foundation was to create a model that had 2 attributes for forecasting. One had good statistical forecast performance. That is, if you hold out the last 10 or 15 years of data, go back in time, fix your models, make a prediction, did it do a good job of predicting what actually occurred? And traditionally, if you want forecast performance, you want a model where only time is on the right-hand side. That's what most econometric models and most demographic models are. That doesn't make it very useful for decision makers who always want to know, well, how would the future look if I did a better job on tobacco or if I scaled up vaccination for children faster? And so our goal here was to create a forecast model that straddled both of those worlds, a causal model and a causal model that had good forecast performance. We've been able to do that. It's sort of a complicated model. I'm not going to go through it. It has 3 components that work together to achieve both of those goals. It came out last week. And let me just give you some of the high-level findings, because we think this is a really important direction for the GBD for the translation into policy use. So on the top, this is for the world. On the top right is fertility. The blue line is our statistically most likely to occur given what we've seen in the past, our reference forecast. The red line is an alternative scenario, which is a worse scenario where every independent driver is set to the 15th percentile rate of change observed across countries in the period 1990 to 2016. And the better scenario is where every independent driver is set to the 85th percentile of rates of change. And for fertility, the main takeaway there is that even in the reference scenario, we believe the world will drop below replacement fertility in the decade of the 2030s. So we've transitioned from a world worried about population growth collectively to a world where we're entering in where the decline of global population will start to be a major consideration. In the second panel is life expectancy. We expect progress in life expectancy to be slower in the next generation than the past generation. That's driven in a large part by obesity, but not just obesity. But notice the huge range between better and worse, meaning that the future is not hardwired, and what we do about the key risk factors, what we do about educational attainment, can have up to an 8-year variation in life expectancy at the global level. And then on the left panel is population age structure. And what you should notice there on population age structure is as fertility declines, we may end up with many fewer children, but that gets compensated in terms of total population by many more older adults. And so they have compensating effects. So on the bottom right panel, there's not so much variation in population, at least in the next generation. Now, these are tricky diagrams. These are called ternary plots. In fact, the first reviewer, when we first published these, I think 20 years ago, did call them tricky diagrams. But they're actually pretty helpful for thinking about the composition of 3 big things that we said go into the burden of disease: the communicable, maternal, and neonatal. That's down on the bottom left, injuries on the bottom right, and NCDs on the top. And the closer you come to the top means more and more of your burden profile is dominated by non-communicable causes. And I really draw your attention to sub-Saharan Africa, where in our reference scenario, still half the burden of disease in 2040, 10 years after the SDGs, in the reference forecast will be from communicable maternal and neonatal causes, meaning that we need to do a lot more to accelerate progress if we want sub-Saharan Africa to go through the epidemiological transition and to even come close to some of the ambitious goals such as zero HIV, TB, and others in the SDGs. The last one for our Canadians in the audience was to leverage the tool that's like any of our analyses. We tried to make all of the details widely available. So there's a tool online called GBD Foresight. Alan and I pulled this off this morning. This shows on the top right panel cardiovascular diseases in Japan, Australia, US, Mexico, Canada, and New Zealand. Canada, for those who want, is the darker orange color. And that's the past trends in cardiovascular disease, and our reference forecast has declines continue, even though there's this disturbing flattening that we've observed in many Western countries in cardiovascular disease. And in the worst scenario, where we don't continue progress on tobacco and alcohol and blood pressure, rates could largely stay constant. And on the far left is a jitter type plot that shows the distribution of countries by the age standardized rate in 1990, the age standardized cardiovascular rates. Each dot is a country in 2016, progress in the reference scenario, the better scenario, and the worst scenario. So lots of ways to explore how the future may unfold and how that's a function of what we actively do about the key drivers. So let me close with some reflections from Alan and I on what we've learned over the, I guess, 27 years of doing this. One is, if you keep doing the same thing over and over, eventually you might get it right. And so that's sort of our ethos. But more reflectively, we've learned that there's just an endless appetite for more detail. It doesn't matter if you show state-specific results or region-specific in the UK government. The next thing they asked was for local authorities. You show state results, people want county results. And so there is this drive to ever more detailed information, and that makes sense both for prioritization as well as for evaluation of success. Our toolkit for the GBD is completely transformed by cheap computing and Bayesian methods. So if you go back 10 years ago, we were not computing uncertainty intervals. We were just starting that journey. And the main reason was we didn't have the computational power to take well-known Bayesian methods and apply them at such a large scale. Now we can do that, and we actually, to support the GBD, we have a larger computational cluster, for example, than our genome sciences department at the University of Washington. And our appetite for compute is almost endless for that type of application. One of the things that's comes out of the GBD that we try to highlight at the country-specific level and with donors is that you can't solve all problems with clever computation and methods. You actually need to go and strengthen primary data collection, and Alan hasn't mentioned that he leads the Bloomberg effort at strengthening cause of death registration around the world. And then the other thing that we've learned is that in the era of collaborative science, where the GBD has transformed into this very large collaboration, scaling that collaboration and how you do simple things like writing papers is a real challenge. We now get 5,000 comments per manuscript when we write manuscripts. And for the lead author on a paper, that's a huge amount of work to read the comments and respond to each of the collaborators who want this, that change in the analysis. But in the end, worth it, but we expect this collaboration that's now growing at 1,000 people a year, if we take the current rate of growth, we're going to have to figure out how to have new tools for collaborative science. Lastly, we strongly believe that the GBD is a global public good and that it's meant primarily at the end of the day to be an accountability tool. It should hold us all accountable for achieving lofty goals like the SDGs and national aspirations. And because of that, it should meet the highest bars of transparency and good science. Thank you very much.